I also had a poster looking at a novel therapeutic in MDS. And so in MDS, once you've stopped responding to azacitidine or decitabine, we have very few options for patients, and it's still an area of high unmet need. In this study, we looked at potential vulnerabilities in patients depending on whether they have a splicing factor mutation or not. There's been a number of preclinical studies, including by a number of collaborators of mine who are here presenting it at ASH this year. I try to identify what is it about splicing factor mutations, which are seen in the majority of patients with MDS. What is it that drives their disease, and is there any Achilles heel that we can use to really target it? When you have a splicing factor mutation, it results in a slowed splicing process, and it uses alternative splice sites. That's all happening on DNA as it's replicated. And so as the DNA gets replicated, it slows down in that process, and you get loose strands of DNA that bind to RNA and create these DNA-RNA hybrids called R loops. Now, obviously, your body doesn't want free DNA dangling around in the nucleus, so it tries to resolve those, and it activates DNA damage response signaling pathway through primarily the ATR kinase. And there are now a number of inhibitors of that pathway, including orally bioavailable ATR inhibitors. And in this study, we took an ATR inhibitor, AZD6738, or Ceralasertib, and we administered it to patients with MDS, as well as CMML, who either had splicing factor mutations or who didn't. And we sought to see, can we give it to them after they've progressed on HMA or after they've progressed on otherwise frontline therapy? And is there any signal that we can see for this agent? Are we possibly targeting this vulnerability? And so, primarily what I'm reporting at this meeting is that, we were able to administer it. The main side effects seem to relate to cytopenias, and so patients will develop some low blood counts on therapy. That's not necessarily a bad thing in MDS as long as you get recovery. Most of our agents do result in a little bit of a cytopenia, but you have to balance, can we safely administer it? And we're currently looking at an alternative dosing schedule, as well as evaluating responses to more formally assess how effective it is. To date, we have seen some signs of clinical activity. Interestingly, those signs really seem to be mostly in the patients who have splicing factor mutations, so a little bit akin to the preclinical rationale that splicing factor mutations would make people disease vulnerable to ATR inhibition, whereas if you have no splicing factor mutation, you may not be as sensitive. And so we're hoping that in our next update, we'll be able to really illustrate what responses we're seeing and map out a pathway where if ATR inhibition is going to have a role in MDS, we can really move it forward to try to treat more patients.